Good evening, everyone. Welcome to the October meeting of the Academy of Integrative Health and Medicine's Cleveland chapter. I'm Peter Geller, co-leader of the chapter, along with Dr. Amy Cipolla, who is also here, and Dr. Jacob Wolf, who is our outreach chair. And so tonight, we are excited to be presenting a talk on using the direct primary care model in family medicine practice, presented by Dr. Lillian White. And Dr. White is a board-certified family physician who practices from an integrative and holistic perspective. And she is also a functional medicine practitioner certified by the Institute of Functional Medicine. After completing a 3-year residency at the Cleveland Clinic in Family Medicine, Dr. White established Empowered Health, which is a family medicine practice in Rocky River, Ohio, and that employs the DPC model that she's going to be talking about. So this evening, we're going to hear a little bit about the genesis and the development of the model itself. And Dr. White's going to discuss the advantages as well as the challenges of working on a monthly subscription basis rather than the traditional fee-for-service model. And then having just completed a full year in this very type of practice, she is going to share her perspective on the model and her personal experience of working with it. So any medical students who are here or residents, anybody who's considering what to do after they actually graduate and start practice, these comments will be of extreme interest to you, I believe. And as well as any practicing healthcare professionals who are curious about an alternate workable way of conducting business. So I'm sure you'll all be quite interested in what she has to say. Before I turn the floor over to Dr. White, though, I wanted to take just a moment to put this talk into a little context, really. For those who don't know, and many may not because it's been a while, Dr. Lilly is actually also a past co-leader of the Cleveland chapter. Our chapter was reconstituted 5 years ago in 2019, and the inaugural meeting was held at a local library in February of 2020. And then immediately after that first meeting, COVID hit, and then nobody was meeting any place for a while. But a few months later, the AIHM did figure out how to do Zoom meetings for meetings. And so then we started doing remote meetings. And one of the very first talks that we had under that system was Dr. Lilly, and her topic was DPC, the DPC model. And she looks like she doesn't even remember having done that, but she did. It was a great talk, and she had invited a practicing family physician at that time who was using that model, and he had very illuminating things to say. So the reason I'm telling you this is because now here we are 4 years later for a talk on the same topic, but from a very different vantage point, right? So these two talks trace a line from what I'd call inspiration and aspiration to now realization, manifestation, and solid experience. So I think it's like a kind of inspirational track myself. Any questions or comments, please put them into the chat. We'll pick them up after Dr. Lilly is finished. And I just want to say 2 other quick things. The talk is being recorded, and you'll be able to access the recording after a little while, and I will notify you in an email when it does become available. As long as you have registered, you will receive that email. And then finally, I just want to do a little peek into next month. Dr. Lilly is going to return to moderate a panel. As many of you may know, we've been alternating, for the most part, individual talks with panel discussions on some, at least distantly related topic. And so this panel is going to be just a blast because we're going to have 3 medical students from CASE and 1 who is now a resident and has been with us for a couple of years as student liaisons, a couple of them. These are the most bright, articulate, excited, enthusiastic, inspirational medical students you'll ever hear. And they're going to be talking about their future aspirations for practice, their visions for it, as well as of the healthcare system that they expect to or want to navigate once they start in practice. So I hope you'll join us for that. It's going to be November 10th, Wednesday at 7. And of course, there'll be an email in the monthly newsletter. So without further ado, Lily, the floor is yours.
Oh, thanks, Peter. That was a super kind introduction. Yeah, it's incredible how quickly 4 years go by. Let me just pull up my screen here. Present. Is that presenting okay?
Yes.
All right, perfect. Well, yeah, excited to be with you. So we're going to be talking about innovation in medicine. Direct primary care is the name of the practice model. So first, I want you to go back, take a step back a minute, and whether you're in med school or already practicing, go back to that idea of when you wrote your personal mission statement, what were you thinking medicine would be like? How did you anticipate practicing medicine? What kind of things did you expect to be doing? What kind of relationships did you envision yourself having with patients? So it might look a little bit different from this model. So this is kind of our current healthcare system. I don't think I need to belabor this point too much, but a little different maybe than your personal mission statement at the beginning of training. So the patient gets sick, they might be on the phone, they'll call, be on hold for a while, maybe eventually they'll get scheduled. If they do, hopefully it's not too far out, might be months. They'll finally see their doc for, a few minutes, who knows how long. It'll get billed to insurance. Not really sure what that is going to cost up front. A lot of times they'll get that bill in the mail later and kind of find out. So this is sort of the current state of things. Again, won't belabor this point too much. I think we've all sort of learned and experienced this to some degree. Let me get it back. So, okay, a little bit more about why are we where we are at now, and how can we get a little closer to that personal mission statement or that ideal way of practicing medicine we initially imagined. So what would an ideal doctor's appointment be like, look like, feel like, sound like? This very much was at the top of my thoughts when I went to medical school and then went through residency. How can I get as close as possible to practicing medicine the way I initially envisioned? This is my cute niece, by the way. So being able to practice in an ideal way allows me to spend some time with her as well. So but we also have to be able to pay our bills at the end of the day, right? We could see people for free and spend tons of time with them, but at the end of the day, we do still have bills and we do still need to make it practical and feasible for the world we live in. So how do we do that? And could we do that in a way that would allow us to still be able to spend time with folks, be able to practice medicine in a more holistic way, as I think a lot of us here, are interested in from integrative medicine perspective. And how would we do it in a way that feels good throughout the day? So that's just where direct primary care comes in. So it's one pathway. I definitely don't tout it as the answer for everyone or for everything. Hence the name direct primary care. So it's for primary care medicine, but it can really be adapted and is being adapted for subspecialists, for specialists as well. So just one option, one more thing to learn a little bit more about, and maybe it'll be for you. So going back to why did I even come to direct primary care? A lot of it is being able to practice those values we sort of mentioned a little bit at the beginning. So being able to spend time with patients, being able to practice more holistically. I saw direct primary care as a way to be able to do this. So it's a payment model, it's a practice model, whereas integrative medicine is a way of practicing medicine. So making that distinction. So for me, my story is during medical training, I was looking for an integrative doctor to be able to shadow. I knew early on in my medical career that that's the way I wanted to practice medicine more holistically. And I was connected to Dr. Jonas, who's down in Dayton. I went to school at Wright State, so he's down there. And I really got to see him transition his practice from a fee-for-service insurance-based model to direct primary care, and how that really allowed him to spend more time with patients, be able to be more available for them. We did some home visits together. He was the director of the free clinic. He did a lot of teaching. He did some writing, very active in advocacy. So my exposure to his mentorship and what his career was like was very formative for me. I was like, this is the kind of doc that I want to be. This is how I want to practice. And of course, as we continue to go through medical training, I felt like that was just more and more solidified as I did get to experience and be on the other side of the 10-minute visits as a physician in residency. And just found that that was just really not the model for me. Maybe some people can do a 10-minute visit and feel like they did a good job, but for me, that just wasn't enough time to build rapport and feel like I was caring for the patient more holistically. But of course, as a resident, it can be kind of daunting to say, okay, I'm going to finish residency and start a practice. So I was very much on the fence of, do I start a practice now, or do I wait and work a few years? This was very much on my mind during my second year of residency. I ended up going on a trip to the Redwoods, which is where this picture is from. I was actually teaching an integrative medicine workshop for an elective that's out there in Ben Lomond. And on that trip, that is when I really, just really had the realization after much prayer and thought that I just need to do it. This is how I want to practice medicine. And it's, some hard things are worth just jumping into. So I'm a Christian, so for me that was very much something I felt God leading me to do, is just to go ahead and start my practice and take it as it comes. So that's how I ended up jumping into DPC right after residency. So I went from that previous picture you saw to direct care. So direct care is the patient's sick, they see their doc. It's a lot more simplistic. I'll go through it a little bit more in detail, but I think this picture really captures what direct primary care aims to do for the doctor-patient relationship. So technically, direct primary care, just defining it a little bit more for those that are like, what is this thing she's been talking about that has been so helpful? So direct primary care, this is the basic definition, charges a periodic fee. So usually that's monthly, but it can be annually. We don't bill any third parties on a fee-for-service basis. So this means don't bill insurance, essentially. And any per visit charge is less than the monthly charge. So if somebody is going to charge per visit, it's less than whatever their monthly subscription or annual subscription is. So this is a very, very basic definition of direct primary care. So essentially, it's a membership model of payment. So comparing DPC to the typical insurance model you're probably more used to or familiar with. So on a typical primary care panel, for those that take insurance, it's at least about 2,500 to 3,000 patients per physician. So that's a lot. If you do the math, it's actually pretty hard to see everyone even for an annual exam, let alone when people are sick or have chronic follow-ups, when you have that many patients to take care of. Whereas in direct primary care, usually about 300 to 600 for a panel, maybe more or less, depending on, the physician. A good saying in DPC is, if you've seen one DPC practice, you've really seen one. We're all a little unique, but I would say this is kind of the general estimate. In an insurance-based practice, you've probably experienced this. You call for an appointment with your doc, it's a 2 to 3 month wait. Hence the urgent cares, right? If somebody's sick right away, usually they're not getting in with their doc. They're getting in with urgent care. And that is partly because in the insurance-based model, if you're not seeing a patient, you're not making money, right? So it's a volume-based practice. So the more patients we see in a day, the more money we make. So it actually incentivizes the insurance-based model to see more people in a day, to have their schedule booked out 2 or 3 months. Because if they don't have somebody booked in that time slot, they're not making money, right? So that's why the sick visits are less and less in a insurance-based primary care practice. Then we talk about messaging. So often 2 or 3 days for messaging in the insurance-based practice. More and more, we're starting to see MyChart messages, for example, being reimbursed by insurance. But a lot of it still is just not really reimbursed. The physician is spending time after clinic or in between patients sending messages, but they're not making anything for that time that they're working. Whereas in a direct primary care model, there's that direct communication. So patients have my number, they're welcome to text, they're welcome to call. We'll talk a little bit about healthy boundaries later, and how you can set that up. But there's no my chart, it's coming to me and I'm responding. Whereas in an insurance-based practice, often it's the office saying, thank you for your message. We'll let you know when the doctor responds, or maybe pass it along. In the direct primary care model, there's also same or next day appointments. This is possible because patients are paying per month or per year. So the physician doesn't need to fit so many visits into a day. They have the time, the ability to spend more time with patients and have those available appointments for sick visits, because it's not a volume-based service. So it's based on who is paying me per month rather than how many am I seeing per day. And of course, if you look at the panel size, it's a lot less. So that also allows for more flexibility in scheduling. And again, at the very bottom for insurance, how much is it, right? The fees are very ambiguous. I'm sure you've all seen those crazy bills patients can sometimes get. And it's hard to have a lot of transparency up front with them. I would have patients come in for a procedure or a joint injection or a skin biopsy. I couldn't really tell them what it would cost up front. I was like, I don't know, chat with your insurance, whatever your deductible is, however, do they cover my office? There's so many unknowns, and often patients just find out what the bill is later. And that can sometimes keep them from seeing the doctor, right? Whereas in direct primary care, the pricing is very, very transparent. That's really, I would say, one of the values of a lot of DPC docs is that we're very transparent with what things cost up front. I'll show you my website and stuff later, but if you go on the website, my pricing is there. It's very transparent. And there's no, surprise bills. It's always upfront. This is what it would cost. If patients are going through my practice, sometimes they still choose to bill insurance for things like labs and imaging, and that's a separate thing. But for me, for my services, no surprise bills. So this again is just kind of an infographic showing the conventional fee-for-service model versus the direct payer model and really what we're striving for. So because direct primary care, we don't bill insurance for our services, we don't have those administrators you see over here. The insurance company, again, cut out, regulator, cut out. And then, of course, those long wait times, unknown bills are also not a part of the equation. So this is a little bit more about empowered health. So these pictures are from the trip where I made the decision to go ahead and start empowered health. I decided this the spring of my second year of residency. And then I opened just a few months after graduating. So about 18 months after I decided I would open is when I opened. So I had a lot of lead time because residency and when I made that decision. I know docs who have opened as quickly as 3 months. I would say to do it maybe a little more comfortably, at least 6 months would probably be pretty good, but people can do it, fairly quickly. So this is from my first day in the office. As part of having your own practice, you get to learn how to do a lot of things that maybe you didn't learn in medical school. So for me, that meant learning how to put on vinyl stickers on a window so I could have a sign for my practice, which is really fun. I learned how to make a website. So the website you'll see is totally my design. And then, of course, learning a lot about the business side of medicine. I was very, very fortunate in that I had another mentor who did direct primary care. And he was gracious enough to allow me to he spent an hour with me every month where he would answer all the questions I had built up from the month before. So I didn't, have to keep messaging him throughout the month. We're like, let's just set up a meeting and he answers all my questions. And it was so incredible, so kind and really, really helpful for being able to get started and answer a lot of those questions along the way. I would say direct primary care community is very supportive of one another. So we're really not in competition. If you think about it, if one primary care doc in the system is taking care of 3,000 patients, whereas in direct primary care, if we're taking care of 300, we need quite a few of us to replace one person that goes DPC. So we're all very supportive when someone wants to transition in the community. We help them get started. I had someone open just in the town over from me, so I've been helping her here and there. So we're all very, very collaborative. There's great Facebook pages where we answer questions and help one another. So when people ask, do you need like an MBA to start your own practice, to start a DPC? I would say no, there's definitely so much support amongst all of us. We're happy to help. So yeah, you definitely learn a lot along the way, but there's a lot of support. So this is just kind of a breakdown of what's included in my membership and how I decided to structure it. So I included all appointments, so phone, video, otherwise are included there. And then basic in-office procedures I did include. Part of that is because if you look at the cost for supplies for these things, it's pretty minimal or zero. So a pap smear might cost me $1 or $2 for the speculum. The lab sends the other supplies for the actual test itself. Joint injection, similar, just a needle, maybe the injection itself, the medication's like $5 at the most, perhaps, but all these things are pretty inexpensive. So rather than nickel and diming people, I just decided to include it in my membership to keep it nice and easy, but people can structure it different ways. So this is just an example of how patients can also save money with direct primary care. I didn't focus on this quite as much for this talk, but here's just kind of a nice breakdown. Because we are outside of insurance as direct primary care docs, a lot of us have joined a group purchasing organization who have negotiated with large labs like Quest or LabCorp for reduced pricing. So patients can save money. I have a lot of patients who, actually, I would say the majority of patients who just pay for their labs because they know it's going to be, they know what the price is up front, it's transparent. So they know what they're paying. They don't have to wait for that surprise bill in the mail. And it can be a lot less depending on their insurance. Some test insurance may or may not even cover if you're talking about functional medicine, right? So here at the bottom, this is public knowledge, so that's why I shared this one. So a blood count $6, CBC's $4, so super inexpensive. Can make it easier for patients to get labs when they may otherwise not, if they're not sure if insurance will cover it. So kind of a cool aspect of DPC. Similarly with imaging, I don't have negotiated prices for these, but there are a few local imaging centers, especially if you're in Cleveland, that have just cash-based pricing. Part of the reason that imaging companies or lab companies are willing or incentivized to offer these lower prices, like why would they do that, right? Is because they don't have to bill insurance, right? So if the lab doesn't have to pay for their billers and coders to get the money from insurance, they can charge less upfront because they know they're going to be getting that money right away. So that's part of the benefit there. Same for imaging companies. All right. So just looking at patient benefits really briefly here. So this just shows some of the cost breakdowns. So like, why would somebody choose direct primary care in terms of cost? So there's some savings from Q Alliance, which was a large DPC. So clearly there's some financial things to be gained there. And you'll notice I like this bottom number. There's an increase in primary care visits. So when patients have access, they're going to use it, right? All right, so now looking more for this talk, looking at the clinicians benefit, so I can speak a little bit more to this. So personally, this has been one of the most professionally satisfying decisions I've made with my career. I feel like a real physician now. I was talking with somebody, I had an open house for my 1-year celebration a few weeks ago. And he was like, how do you feel? How has 1 year been? And I told him I felt like I was living my medical school personal statement. I have those relationships with patients. I know them when they call or text. I know a lot about them and their families. We've been through some ups and downs together, and I get to spend time with them. I get to provide more holistic, personalized care. And I just absolutely love it. Even professionally, I have admin time. So I set aside time to look at more complicated cases, to go through their labs one more time, go through their history, their notes, their specialist visits. I have time to do those things, to be able to take care of more complex patients and feel like I'm putting my best effort forward for them, and stay on top of the latest research, right? In the insurance-based model, there's really not a ton of time for that. Somebody's cramming, a ton of patients into a day. There's not as much time to be curious, to look up the latest research. And I think especially for us as more integrative, holistic, functional clinicians, we really value the cutting edge research, and what do we know today that we didn't know a year ago? So that's been just very professionally satisfying. And then potential for more stable income. So I have some friends who joined like a fee-for-service model private practice, and they are working. If they are not working, they are not making money for that organization. So it can be pretty tough. Whereas in direct primary care, patients are paying, on a monthly or annual basis. It's pretty easy to say, okay, I'm making this much this month. If I take a day off here or there, or, need vacation weeks throughout the year, I don't have to worry about not making money during those times. I'm still, available for patients. I make sure I have backup. There's a lot of ways to go about it, but that hamster wheel mentality just isn't there for it. And then looking more at like the clinical side, so reduced overhead. This may not be maybe as exciting a point, but I think it's worth noting, especially if you're working or have your own private practice. So you probably know that most of the overhead of running a fee-for-service practice goes toward billing and coding insurance. So if you cut out insurance, it saves a ton of money on overhead, which you can then pass along to patients and use in other ways. So super huge point is reducing overhead. And I'm happy to share, some of my own numbers or whatever is helpful. We can do more during the Q&A. And then, of course, the revenue structure is simple. Documentation, pretty simple. What I'm documenting is whatever is necessary medical legally, and what I need for my own memory to remember what we're doing and have a good treatment plan. Whereas in the fee-for-service model, previously there was the review of systems and having to code this with this, or make sure if you don't include that code, you're not going to get reimbursed as much. And so that stressor isn't there. And then, of course, smaller patient panels, because I'm caring for, 300 to 600. I have more knowledge of them. I know what's going on with them. And actually, malpractice recognizes that too. So malpractice for physicians practicing direct primary care is often much, much less, because they recognize we have more time with those patients and there's less of them we're caring for. The liability is just less, which I think does speak something. So sometimes I'll get asked, how do we distinguish between DPC and concierge? So technically they are different. So concierge medicine, yes, they usually have a retainer. So that's that monthly or annual fee. But on top of that is the insurance. So concierge technically by definition also bills insurance on top of the monthly or annual fee. Typically, and that's, their main source of revenue is actually from billing insurance. Typically, concierge physicians also have a smaller panel, so maybe closer to 200, although like we said before, DPC can vary quite a bit. And then additionally, usually the annual or monthly retainer is a lot more. So whereas most DPC docs are like, I would say 1,000 to 1,500 a year, concierge is typically 3,000 or more a year for care. So this is a map of all the, or at least a lot of the DPC practices in the country. There's about 2,000 or 3,000 of us, and it's growing a lot, a ton. So on this next page here is Ohio. So Ohio has about 70-ish DPC practices as of about a year ago, and more are opening all the time. I know we've got at least 1 or 2, actually 3 opening in Cleveland as of this year. So very, very cool. Let me see here. And then I just wanted to show you a little bit from what 1 year was like, and then I'll open it up for questions. So 1 year for me, this was my open house, so a ton of fun. I got to, the mayor of Rocky River, so the town where I'm at, hosted this ribbon cutting ceremony with the Chamber of Commerce, which was just super fun. So kind of cool to like experience a little bit of the business world of things. I was nominated and received an award as one of the top young professionals in Cleveland. So that was very kind. I have been on the board for several organizations. So because I have my own practice, I am in control of my schedule. So I have more time to provide some service to the community in the form of boards, which I have actually really enjoyed. I actually won one of the best doctors of Cleveland for this year. So this is 5 physicians, 4 physicians. So my colleagues, I guess, nominated me for this, and was really surprised. Very sweet, really cool thing to earn in the first year of practice. And then I got to do 10 workshops. So I really love hosting workshops. So if anyone ever wants to collaborate, I'm down. This was from one with the local CrossFit, which has been a really great community resource to work with. I hosted a student for a couple months. So if you came through my office over the summer, you probably met Sydney, who's really wonderful. I got to do a lot of teaching. I'm also adjunct clinical professor at both OU and CASE. So I get to do a little bit of teaching and precepting with them and really, really enjoy it. So I schedule my time where I can block time to teach and really love mixing up my schedule that way. I'm also an editor, so contributing editor for the main family medicine journal, American Family Physician. I help with their blog. So every other week I get to write a blog for them. I've had a lot of publications this year. So because I really love writing, I can set aside some time in my clinic schedule to be able to contribute in this way and be able to stay, really I use it as a way to stay on top of the latest research in medicine and learn more and more. So I really enjoy getting to do some of the other aspects of a career in medicine. So it's not all clinical care, although I love that too. So relationships with patients, we touched on this a little bit, and I wanted to share just a brief story. So when a few weeks ago, I had a patient who came in and she mentioned I had seen her nephew a few weeks prior. And when I had spoken with him, came from a really, really rough background, had some drug use issues, some really tough PTSD, was just in a really rough place, but very kind of stoic on the outside when I was talking with him at our initial appointment. I saw his aunt a few weeks later and she told me like, wow, that he came home and cried. Like that was such a meaningful appointment to him. He had never had a physician care for him in quite that way, where he could feel cared for, like somebody valued his health. And I think that just really demonstrates the power that a different practice model can have, where we have time with patients and time to care for them in a more holistic, personalized way. So now that you have heard this and know this, thinking about maybe how do you want to redesign your own practice or maybe start designing your practice. So definitely feel free to contact me. I put my email at the bottom. I'm, probably once or twice every 1 to 2 weeks, I'm talking with somebody who's interested in DPC or coming to shadow, or just chatting with them on the phone, getting coffee. So I've had so many people pour into me who've been resources for me. So I'm definitely happy to pass it forward. So with that, I'm going to stop sharing my screen and open it up for questions. And then at the end of that slide deck, I think I'll be able to share that later. I put a bunch of resources. If you're interested, you can kind of click through them.
I'm not sure if we have, do we have any questions in the chat? I don't think so.
I saw a hand raised really quickly. If you have a question, if you can just stick it in the chat, that would be great. Otherwise, if you want to raise your hand, I can unmute you as well.
Well, I'll start the ball rolling, actually, if nobody else has got something right away. So I have two questions, Lily. One is that, you know, it does really sound like an ideal setup and everything sounds great, but my question is, have you found any challenges along the way, or has it just been, all
That's a
advantages?
good question. Yeah. I would say part of the challenges are, anytime you're starting a business or a practice, like definitely, not going to be all butterflies along the way. It does require, some dedication at the beginning. There's a lot of time put into building the website, filing the LLC, learning how to format things legally with contracts. So yeah, there's a lot from like that sort of MBA perspective to learn. So I would say I've met people who are like not interested in that part at all and didn't really work out for them to start a practice because they just didn't like to do those other things. I have known people who have been successful farming those other things out to people or contracting them out to other people, but that does increase the cost up front, which can make it harder to kind of become more profitable or sustainable at the beginning. So I would say that's one consideration. So I enjoy learning new things. I enjoy kind of the entrepreneurship life, getting to know people in the area. So I've enjoyed it, but I would say it definitely has its moments where it's challenging, just like any other new endeavor. I would also say if you're starting from residency, so depending on when you start your practice, there may be some financial investment at the beginning. So for me, I chose to make a little bit less this year and last year because I started my own practice. I could have taken a job and made, whatever normal family docs make. But because I'm starting my practice, I worked some side jobs while I was starting. And yeah, definitely took some financial investment up front. But in the next 6 months, I'll be making the average that a family doc makes and be working maybe 3/4, half as less as they do. And enjoying what I do and loving what I do and being able to maybe work till I'm 80, 90. So we'll see. So
Cool.
yeah, definitely some upfront investment at the beginning though, in terms of finances.
Great.
And
We have a couple
my,
of questions in the chat.
I'm sorry. My second, I just had one more question and then I'll stop. So I know you don't bill insurance, but if a patient has insurance and there is some extra charge for something, would you give them a super bill with diagnostic and procedural codes so they could seek their own reimbursement?
Yeah, that's a good question. I don't, because it's more paperwork, administrative work, and I don't enjoy doing that. I just don't think, yeah, I would have to charge more for my services if I did that, so I don't. I just think it kind of sets you up to go back to the insurance model when people start doing that, honestly. But some people do.
Okay, thank you.
All right. So in the chat, we have the question, how do you handle being available to, oh, I'm sorry, hold on. First one was, how do you manage patients that need to be hospitalized?
Yeah, good question. People do it in different ways. I have a patient being hospitalized on Friday for surgery. She may or may not stay overnight, so I'm gonna check in with her Friday afternoon. If she's still there, I'll go check in on her. That's just my personal preference. I have privileges at Fairview Hospital, so if you're in Cleveland, you know where that is, but so through the Cleveland Clinic. But the way I've worked it out is I can go and check on them. I kind of work behind the scenes to make sure the patient knows what's going on, things are being done in alignment with their values. The hospitalists are on the same page with the patient. So kind of working to make sure everyone's on the same page. Whereas I'm not the admitting physician. So some people do still admit to the hospital, but the culture with hospitals around here is they page for silly things in the middle of the night. So I just didn't want to be that person on call all the time, but I still wanted to make sure my patients got the care I think they need. So that's how I manage it.
Great. And then next question is there a minimum amount of appointment services that membership guarantees to patients?
Yeah, if you kind of like the idea, if you've seen one DPC, you've seen one. So everyone may have different answers for this, but for mine, I don't limit visits. I don't place a limit on things. Some people would say like, oh my gosh, a patient could see you every week. Yeah, they could. But if someone needs to see me every week, there's probably an illness, anxiety disorder, or something going on, right? And in that case, actually the treatment for that is, you guessed it, regularly scheduled visits. So yeah, so I think that's how I've chosen to manage it.
Great. Do you feel that patients of a certain income level tend to utilize DPC practices more?
That's a good question, actually. I was kind of interested to see how this worked in my own practice. And actually I have people from all over the social economic status. I have some people who plunked down the year fee and they're like, didn't even think about it. And I have other patients who I actually give a discount to because they are, it is such a stretch for them. And I cared for them before. So it's your own practice. You can give discounts where you feel it's needed or you're able to. But yeah, I definitely have patients all over, honestly.
And are there DPC practice groups?
Um, I think this is asking if like there are multiple like doctors in a group, and yeah, there are. So there's a few different ways people do it. So there are groups where it's physicians working together in the same group. Um, there are what we call like employer DPC groups. So it's like a franchise of DPC. Most recently, there's one called, excuse me, Marathon Health. It used to be called, I think, Paladina in the past. So they have essentially a franchise. They have offices all over the country, and then they only contract with employers for DPC. So that's where they get their patients.
How do you handle being available to your patients all of the time?
Yeah, I think this is great. And again, if you've seen one, you've seen one DPC. People have different boundaries or ways they want to do this. The way I chose to do it is I tell patients kind of like having a doc in the family. So I tell them I can't promise 24/7 because I would have to charge a lot more and I just don't want that lifestyle. But if patients call me, they have my number. If they call me after hours for anything that's urgent, so urgent would be they're not sure if they need to go to the ER or urgent care or can't wait till the office is open, they're welcome to call me and I'll get back to them as soon as I can. I think in this modern world, most of us have our phones on us anyway, so I'm happy to help as I'm able. And then I tell patients they're welcome to text anytime and I'll just respond to text messages during business hours. So they get kind of an automatic message from my system that says, hey, it's after hours. If it's urgent, call. So it helps to remind them. But people are really, really respectful, honestly. Um, when they know that they can reach you during the day, they reach you during the day. I've only had 2 after hours calls in the whole last year. And both of them were very appropriate. I'm glad they called. So yeah, people are really respectful. It's like having a doc in the family, right? You're not gonna wake your brother up at 2 a.m. for a cold. Kind of same idea. So yeah, I've just been very, very appreciative of patients. Yeah.
Great. Do you have any advice for those of us with a substantial amount of student loans who are considering staying in nonprofit to qualify for PSLF but want to work for themselves?
Yeah, great question. Yeah, I guess part of it would be, yeah, working for yourself, unfortunately, just doesn't qualify for PSLF. So that's just not an option. So you have to kind of choose one or the other. Maybe they'll change things and that would be wonderful. But yeah, right now, what I do doesn't qualify for PSLF. Although I think anything in primary care should really count, is my opinion. But yeah, so I actually did the math for myself and depending on your values and how you want to do things, I found that if I just live like a resident for 2 or 3 years after residency, that I can pay off those loans, and then I'm a free agent. I'm a free person. I don't have to work for a place that I don't, in that practice model that I don't think agrees with my values for another 5 years or more just to pay it off. I can just have a lower cost of living, or not lower cost of living, spend less on my lifestyle for a few years and be able to pay it back even quicker, actually. But if people have family or other considerations, that may not be quite as much of an option. Um, But yeah, those are kind of the considerations.
Great. How do you manage childhood and adult vaccinations?
Yeah, great question. I think this can be tricky in DPC depending on we're working on coming up with a better solution. So currently the way it works is I can actually order vaccines and I can give them in my practice, but patients would have to pay out of pocket for them. Some patients without insurance, this is a great deal. So what it costs for me to give a flu shot is like less than half of what it costs for someone to go to like the pharmacy down the street. So it can be a lot cheaper if patients don't have insurance or don't have a way to pay for vaccines through insurance. Now those that do have insurance, usually I'll have them just go to either the health department or the local pharmacy. If they want to use insurance, that's pretty easy. Where some docs have been able to do it is if you give enough, like hundreds of vaccines in a year, so bigger practices, they can set up an account with what's called VaxCare, where they can bill insurance through that and have it in their clinic. The problem with that is VaxCare doesn't work with smaller practices yet. We're working on it. So maybe eventually we'll have that up and running. There's some pilots kind of going on right now, but yeah, for right now, that's kind of the workaround.
Sounds good. And then this is so encouraging to see such a great patient-centered model. Where do patients find the directory for DPC physicians?
Yeah, great question. So if you Google DPC mapper, that'll show that map that I pulled up for you, and patients can actually search by zip code or state to find someone that's close to them. There are a couple other similar tools, but that one's probably the one that has the most physicians on there.
All right, that is all our questions. Thank you so much, Lily.
I think there's one question in the Q&A.
Oh,
Um,
you are right. I'm so sorry I missed that.
it's okay.
What should you look for in residency programs that will best prepare you for practicing in a DPC practice?
Oh, good question. Yeah. I would say, yeah, and I've had different mentors say this before, the biggest thing in medical training is becoming the best doctor you can be. So choosing the residency that will allow you to get the best medical training is really key. There are, depending on which specialty you go into, there is some training regarding starting a practice, but I would say across the board, most residency programs aren't teaching folks how to start a practice. A lot of this is going to be self-directed. So it's kind of outside the residency program. Some will let you do like electives, so you can make your own elective. I did this during medical school, actually. I made a DPC elective where I spent a few days with different docs in the region and really got a taste for how DPC could be practiced in so many different ways and gave me a lot of ideas for my own office down the road. But yeah, when it comes to actually starting something, I wouldn't expect it to come from the residency. I would say that'll be a lot more self-driven. I put some resources for that at the end of the slide deck, but one of the biggest ones I would say is called the Direct Primary Care Alliance. So it's actually free for students and residents to become a member. And they have a lot of great materials, conferences, things like that, mastermind sessions people can go to. And then there's a big summit every year. If you're here in Ohio, we're having an Ohio summit in February, so feel free to reach out if you're interested in info about that. But yeah, a lot of books, a lot of mentors. Yeah, pretty self-directed actually.
If nobody has any other questions, I'd like to ask a final one and ask you to be a visionary for a second. What would our healthcare system be like if there was only DPC type practices, if that were possible, and that insurance was really way in the background if it was there at all? What would it be like, do you envision?
Yeah, that's a good question. I love it. Yeah, I think like gosh, I think we would have a lot more happy physicians. I think that would be amazing. I wouldn't expect the burnout rate to be so high. I really like love what I do. And I think we'd be practicing at the top of our license, right? There was a really great article Kenneth Q wrote, I think it was for DPC News a few weeks ago or maybe a couple months ago. about how direct primary care currently is kind of like a triage system. So patients go in and they get triaged to the dermatologist, the cardiologist, the GI. Whereas when you have time to build up expertise and talk to the patient more, you can really actually take care of 80 to 90% of what patients' needs are. I shocked some med students when I shared that statistic with them before a clinical session. And I saw one later and he was like, I don't believe you only refer 10 to 20% of your patients. And I was like, it's true, come shadow. And I think that would trickle down to specialists, right? If they're seeing patients that have been triaged already and cared for already by primary care, they're going to be able to practice at the top of their license and have more professional satisfaction. So anyway, I think all around it would be really great for our health system, but also for individual physicians as well.
Happy doctors and happy patients would be the answer.
Yeah, I think so. I'm a little biased, but yeah, I think, gosh, I hope we're more and more we're going this direction. So.
Well, you're biased with justification, though. You know, it's not like out of the blue. You have good reason for your opinion. Thank you so much, Lily, for your, it was really great. Hope everybody enjoyed it. I think everybody did, because we didn't really lose anybody in the course of the whole event. And so I want to thank everybody for coming once again. And again, we'll notify you as soon as there's reporting up. Do you want to listen again, or you want to forward it to or refer it to anybody else who didn't have a chance to attend tonight? That would be okay too. And then come next month to hear the panel of enthusiastic med students and residents. So thank you.
Thank you so
Thanks,
much.
Peter.
Take care. Bye-bye.